Hey, everybody, I'm here today with a really special guest. I have Dr. Tanya Dempsey from the AIM Center for Personalized Medicine, who is one of the leading Lyme literate doctors. And we've been fans of hers for quite a while. Rich has had the opportunity to interview her twice. And now I'm happy to have her on for the long form podcast to get a real deep dive to understand how you're helping Lyme patients and how what you're doing can be scaled and how people listening to this podcast can learn and benefit from everything you've done in your career at Dempsey. So thank you for joining us and welcome to the Tick Bootcamp podcast.
Thank you for having me. Looking forward to this today.
So, Dr. Dempsey, before we jump in any further, let's talk about your background because we did some research on you. And I think it's really fascinating to know that by the time you were 5 years old, you knew I'm going to be a medical professional. And there was no plan B. It was it. You were a 5 year old Dr. Tanya Dempsey, and that was it. So, what brought you to that point as a 5 year old child?
I had an amazing role model in my life. My maternal grandmother, my mother's mother, was I guess we'll call it the equivalent of a nurse practitioner in Russia during World War II, before World War II, into World War II, and after. And when I was growing up, I was very, very close with her, and she practically raised me in some ways. And I just remember her telling these stories about her experiences taking care of patients. And what always resonated with me is the way she spoke about her patients, the relationships she had with her patients. Even at one point during the war, she was in Kazakhstan, which was a primarily Muslim part of the USSR. And here was this like 4'10" Jewish woman who was sort of assigned to this village. And the respect that she gained from people who were different than her was really, really resonated with me and always just set an example for what I wanted to do when I grew up. And so I always looked at it as there's nothing else to do but to go into medicine and to help people the way that she helped people in her life. And when she came to America, she couldn't practice medicine, but she achieved great things, learning the language, learning multiple languages. She was very, very, very intelligent, brilliant woman. So she was my example, and so I knew that that's what I wanted to do, and it was a journey to get to from that point to where I am now. Like I had no idea that this is where I would wind up, right? Treating Lyme, complex chronic diseases, mast cell activation syndrome. But I always knew that I wanted to be able to help and treat patients who others maybe couldn't help. I knew that I wanted to be the one.
So at a young age, you wanted to really be a doctor and help identify with the patient as a person and not just a number, which is something that is so rare in our society today. But
Right.
did you appreciate as you were growing up, of course, not at 5, I don't think, but did you appreciate how many people were chronically ill in our society and what impact you'd be having as you advance your career?
Yeah, no, I think I didn't know or understand, but I started to become more aware when I entered medical school. So at that point, I was sort of looking at it as I'm going to be a doctor. I'm going to help a lot of people, and that's the goal, right? And what I started to discover in medical school was that I was always very, very involved or interested in health, overall health. I was, interested in food and the impact of food on the body. So, always watching and trying to be as healthy as possible, working out, exercising, lifting weights, bodybuilding. I was doing all this stuff as a way of, again, taking care of myself. And what I noticed very early on in med school was that not a lot of people were taking care of themselves, those in med school, but then also the patients. And we were being taught, to treat chronically ill patients with medications, right? So we were taught, the person has high blood pressure, you give them a blood pressure pill. They have high cholesterol, you give them a cholesterol pill. And really, after, maybe we had a half an hour lecture on nutrition the entire 4 years of med school. It just became very clear once I was practicing medicine that there was this real disconnect between what I was doing for myself and what I was doing for patients. And it became really hard to keep those two worlds apart, right? So then you start to think, why are we seeing all these chronically ill patients on medication, but not being taught that they have some control? Not total control, right? There are lots of things that happen to people that they cannot control with diet, exercise, et cetera. And I realize that. And of course, Lyme is one of those things, right? But but setting the stage or the foundation for the health will make it just easier to fight other things that you're facing. We were never taught that, and it drove me crazy. And so over time, I just started to share with patients what I was doing. Started to brainstorm with them what they could do to change the trajectory of their health. And so then that's when I started to really, really appreciate the chronic illness epidemic that we were having. And it certainly, I think it's gotten worse over time. And certainly since COVID, I would say the last 6 years has been mind-blowing, actually, the number of people who are sick.
Yeah, and I think there's a lot of factors that go into that. And we're going to get deeper into those kind of discussions about
Yep.
what's causing this worldwide problem with chronic illness. But let's talk about, so where did you go to medical school? Where did you get your MD? And then what was your early career like?
Yeah. Well, I did my undergrad at Cornell. I went to Johns Hopkins School of Medicine, which was the number one med school at that time. I was very proud of that. It was an amazing experience, but again, very, very conventional, and that's okay. I think I learned a lot about a lot of things in medicine that helps me be a better doctor. I finished med school and I went to residency at NYU in the city, and I did a like a joint primary care internal medicine residency for 3 years. And my goal after residency was really to join a practice and to do primary care medicine. And I thought that's what I would do probably for the rest of my life. I think primary care medicine is really, really important, but unfortunately, the way the insurance model changed, and I think the way I don't know the medical establishment is these days. Primary care medicine is more difficult than ever. And at that time, we were, I think it's even worse now, but we were given 7 minutes, 10 minutes, to see a patient. And I started noticing, again, very early on that these patients were pretty complex. And I didn't have the tools to understand it fully, but I knew that I needed to take a good history. I needed to dig. I needed to try to put the pieces of the puzzle together. You cannot do that in 7 to 10 minutes. And so I always ran late and then got reprimanded for doing that. Um, so, um, so yeah, so it's been a journey, unfortunately, away from primary care, but in many ways still with that mindset of being able to take care of the patient in all ways, their body as a whole. And I call it holistic, but whole, WHOL, right? It's a holistic view of the patient, which really I think all primary care doctors should do, but they don't have time to.
Yeah, couldn't agree more. So while you were in the early stages of your career, were you ever exposed to patients that had a Lyme diagnosis or a tick-borne illness?
So I would say not during medical school, right? Zero patients that that had Lyme disease. Now, I believe many of them had Lyme disease, of course. I did a lot of rotations in like rheumatology where we were seeing all these autoimmune diseases, right? And the teaching was these are just people who have autoimmunity, and you just put them on immunosuppressive agents. And looking back, I mean, many of these probably had vector-borne infections, had dysfunctional immune systems due to other things, maybe mold or other toxin exposures, but we were not taught that. But somewhere in my primary care days, I started to see one by one patients either who carried a diagnosis of Lyme. They would come in and say, I had Lyme 10 years ago, 5 years ago. And then I have patients that I started to diagnose with Lyme right at the end of my primary care days before I went out on my own. But it was still, not a lot. It still was not the forefront of my mind. That really shifted once I started my own practice and started to really be able to take a history. And I had some really good mentors who really made me more aware of how important this disease is. And then it just, escalated. And then once you see it, you can't unsee it.
Yeah, and walk us through that transfer in your life where you're going to your own private practice and you're also finding these mentors to help guide you and educate you about things that you weren't traditionally taught in medical school.
Yeah. So I started my own practice in 2011, and it really was. I think back then I looked at it as a risk. A lot of my colleagues that I was working with in primary care or specialists that I referred to, they really thought I was nuts. And I had some of these docs really kind of say some kind of derogatory things to me, and I also maybe a little sexist. Things like you're not going to make it. There's no way. Look at all these docs who are joining the bigger practices, and you're leaving a big practice and starting on your own. That doesn't make any sense. You're never going to make it. I remember this one cardiologist once. He was part of a group that when I first joined, right out of residency. So I've known him, I knew him the longest. We were in the gym of all places on the treadmill, and he started talking to me and just was really, really trying to make me doubt myself. And I had just opened the practice, and he's like, he would name people that we knew. Oh, remember that person? Oh, they didn't succeed. And remember that person? They didn't succeed. And I was trying to explain to him what I'm trying to do is different. So I don't think we can compare. And I feel pretty confident that I can help a lot of people. And he's like, you're not going to make it. And just wait till you come back to us. You're gonna call us, in a year or two when you're not succeeding. And so I went into this, actually doubting myself a little bit with not as much confidence as I really probably should have had. But I said I was just so committed to wanting to give patients what they deserved, treating them the way they needed to be treated, spending time with them because they have a story. Everyone has a story. That story is what brings them to where they are now. I cannot treat them without knowing their story, knowing where they started. And so I said, you know what? Even if I can only help a few patients, even if no one follows me or only a few people follow me, I'll help those people. And so I remember when I opened my first office, it was like this small little office, and I remember telling my husband, don't worry, it's a small office. I think I'll be able to afford it. I'll see a few patients a week, maybe a few patients a day eventually. I don't know who's going to see me, but I want to give it a try. Within a year, I was almost like fully booked, and certainly within a few years, I was like, I had a waiting list already, right? Because people were looking for this type of medicine, which I really thought was very novel, but now I realize it wasn't. It's just that I was never exposed to this before. I didn't know that what I was doing was functional medicine or integrative medicine. I just knew that, and this is how I was raised. This comes from what I learned from my grandmother, what I learned from my mother about understanding the person as a whole and understanding how all the pieces fit together. That was just how my brain always worked. And so I didn't even know what I was like that I was practicing like a special type of medicine until I, talked to some mentors, who were like, oh, it sounds like you're doing integrative medicine. Oh, okay. Is that what this is? Okay, great. So then I named my practice in Armonk Integrative Medicine. Armonk was the town that I opened my practice in and called it Integrative Medicine, and I started. And what was really great was in the beginning, I would give little talks around town. I would give a talk in the local gym. Just to, sort of tell people what I'm doing. I would talk about diet. I would talk about lifestyle. And I would start talking about food sensitivities and gut issues, and it turns out that somebody who was involved in integrative medicine, like putting on conferences and other things, or was well connected in this field, actually attended one of these conferences, and she heard me and she said, I really think that you have something special, and I want to see if I can start showcasing you. And Let's do, can you speak with for me at a upcoming conference? And that was well, not the first time I ever spoke at a conference, but the first time at an integrative type of conference. And once I started doing that and getting more into that field, that's when I started connecting with other like-minded people. And you start connecting with people, and then you start to see, you start to learn from them, and you start to understand who you want to emulate, who makes the most sense to you. What are things that you can learn from them to bring into your practice. And that's how, I started finding my mentors. And I think, the number one mentor for Lyme is Richard Horowitz, who, I consider the premier Lyme expert. He and I were actually speaking at the same conference on different topics, of course. He did his Lyme talk. I did a talk on methylation. And we started, I had seen him before at other conferences, but we had a little more time to chat. And I remember, and he remembers this too, because we laugh about this all the time. And he said to me, so how many Lyme patients do you see? Because Armonk, is endemic, right? And I said to him, so this was really early on, just a couple years after I started my practice. And I said, oh yeah, no, I have a few patients. And he goes, no, you don't. And I just remember that moment where I was like, uh-oh, really? And he said, oh no, no, you're missing them. And I remember this was a Sunday, I went back to the office on Monday. And I remember my first patient that day was a patient that I had really been kind of struggling to try to figure out why she had this sort of multi-system inflammatory type symptoms. And, it was headaches, it was GI stuff, it was fatigue, it was all these like very non-specific things. And I was really struggling to get her better. I would, treat the headache and I would treat the gut stuff, but I was going in circles and I'm like, what am I missing? And so she comes in that morning, right? And I'm like, oh my gosh, I took another history because when you don't know, you always have to start over again, right? There's something they're going to say that you're going to miss. And sure enough, in the second time I took the history, it nailed it for me. She had exposures, risk factors, hiking, some other things, living in Westchester County. And I just looked at her and I said, gosh, we need to test you for Lyme and co-infections. And that, changed the trajectory of her health, that moment in time, right? So, I'm very grateful for what I've learned from Rich, and that really was the start of this career in Lyme disease and vector-borne infections, because again, once you see it, you can't unsee it.
Yeah.
And the other part of that story I'll mention, and then I know you want to ask me another question, but I've talked about this before, but this also was the thing that kind of solidified it for me. Was at that conference, my mother was with me, and she used to come a lot to my conferences. She always loved to hear me speak. And I was one of the first speakers, and then we were sitting together while Rich Horowitz was giving his talk. And he starts talking about different symptoms of the different infections. And she starts turning to me and like looking at me and giving me this look. And she's like, oh my God. And every, symptom he would list, she was like, I have that. I have that. I have that. And she had been on this journey. I'd been on this journey with her for several years with unexplained problems. They blamed it on menopause. They blamed it on a lot of things. And we never really could get to the root of it. And I felt bad because it was my mother, and the whole time she sat there, she goes, "Oh my gosh, I have babesia. It's right there, every symptom on the list." And that was really like my real first patient, right? Because you got to get your mother better. So I started that journey, really trying to get my mother better and my patients better, and that was really that was eye-opening for me. So.
Yeah. And I love, around this time, I know we have a quote from you from around this time in your career where you had said that a normal lab does not mean a normal body. And I think that's when you realize that testing probably was not perfect for Babesia, Lyme disease, et cetera. And that's why you said just because you have a normal lab doesn't mean you have a normal body. So was that something you fully understood prior to this time?
I don't think I understood it fully, but I knew that not necessarily in the Lyme world, but if I went to, let's say, looking at endocrine issues, and endocrinology was always a very, very big, kind of interest of mine. So I treated patients with PCOS and thyroid issues and thyroiditis, and so I already knew that the labs sometimes didn't tell me the whole story. I could diagnose a patient with PCOS and with normal labs. I can diagnose a patient with thyroid with quote unquote normal labs, right? So I already was aware of the issues and what was normal, considered normal by a lab, and what isn't. But once you get into the Lyme world, right, it's a whole other story. So, interestingly, with my mother, it took years to actually get a positive test on my mother. Like I knew she had it, but until we had molecular testing, she has some, underlying immunodeficiency. So all the antibody testing, all the Western blots, all the negative, negative, negative. And yet I know she has all the symptoms. I know she's responding to treatment, yet I can't prove it. And it wasn't until we could get, molecular testing, fish testing in particular, that we finally had that confirmation. And I remember that first time, like we looked at her labs and she saw the bugs, lighting up on the pictures from this fish test. And she was like, see, I knew it all along, but it took, I don't know, 10 years to finally prove it on paper from the lab, right? So that's the problem, right? And listen, she's lucky, right? She has a daughter who's was committed to getting her better and had the ability to do that, right? Not everyone has that, you know, the resource, right? So if you don't know and you're told by a doctor, nurse practitioner, whoever, PA, that you have normal labs, like you have to believe it, right?
Yeah. Yeah, and you're right about the fish testing, right? Because when you're looking for antibodies and you have immune problems, you're less likely to test positive. But the frustrating part is, even decades ago, we've had Dr. Alan McDonald on when he was at Southampton Hospital as a
Yeah.
pathologist, and he was sending us photos from 30, 40 years ago of blood showing the bacteria, the Lyme bacteria in the blood, and we have it on our website now and on his podcast episode. But that wasn't the standard or the norm, so it's very difficult to properly diagnose people with the limited standard testing we had at the time, and frankly, that we still have today, I feel.
Yeah. Yeah. So many issues with antibody testing, and I just wish we could just do away with it and not even bother because it confuses the patients, it confuses the practitioners. And, listen, primarily you need the clinical data, right? You need to talk to the patient. You need to get their history. You need to get their exposure history. That's first and foremost. But I'm a data-driven person. I want data, and the fish testing really has been a game changer because sometimes I might believe the patient has this, but the patient doesn't believe it, right? Because they've been gaslit forever, being told that, there's no way they could have all these symptoms. It doesn't make sense, and it can't be that. It can't be Lyme. It can't be Babesia or Bartonella. And but it's nice to be able to see it on paper and to say, look, this means it's active. If the fish test is picking it up, it's an active infection. It's in your bloodstream. That's driving, a lot of these symptoms. But yeah, but antibody testing just does a disservice for many reasons, right? So number one, when you have vector-borne infections, often the people who get vector-borne infections already have some kind of immune problem, especially infections that linger, so the more chronic issues. So their immune system already is not fighting appropriately. Then these different organisms suppress the immune system even more. Then they're exposed to things in their environment, could be mold, mycotoxins, other toxins. That suppresses the immune system even more. The antibody test relies on the immune system mounting an attack against the organism. The immune system may not recognize that there's something there that it has to fight, or it knows there's something, but it's just not making the antibodies. So then again, you have a negative ELISA, you have a negative Western blot, and if that's what you rely on, even with the other infections, Bartonella, Hensley, Babesia, these are some tests that you could do theoretically through Quest, LabCorp, traditional labs. You're not gonna find it because the immune system is not mounting an attack. Conversely, though, a lot of patients who have immune dysfunction actually have the opposite issue. They actually make too many antibodies. This is sort of in the realm of what looks like autoimmunity, but is not true autoimmunity, but they're autoimmune-ish, we call it. So they're making all these antibodies. They have positive ANAs, positive rheumatoid factors, thyroid antibodies, and then you do a Western blot, and they have every antibody positive on the Western blot. And then you have to raise the question, is this truly Lyme, or is this a dysfunctional immune system that's just overactive and just, showing that it's Lyme, but maybe it really is Bartonella and not Lyme, and maybe it's something else. So either way, too many antibodies, not enough antibodies, it's going to pose the
Right.
same issues that you're not going to know what the patient has.
Both sides of the spectrum. It could be underperforming or overperforming, and they
Yep.
both could have false results, which we have to be mindful of, which is why the
Right.
clinical side of it and the history is so important to make a diagnosis when it's so prevalent. Now, on that note, you talked about true immunity versus autoimmune-ish, right? So can you give us a little bit more detail? How would you define true autoimmunity versus autoimmune-ish? Because I interpret autoimmune-ish is your immune system is dysfunctional because of a microbe, I guess is what you're saying. But then how would you kind of separate those two buckets?
Yeah, I think it's a little more complicated than that. So autoimmune, I would say, is a condition where you have autoantibodies, you have antibodies against self that's actually doing something to the cell or whatever it's attacking. So let's take an example of, I guess, lupus. Now, again, there's some nuances here because some people would say, oh, maybe a lot of people with lupus will actually have tick-borne infection. But I'm just trying to sort of distinguish. There are autoimmune conditions where they have a positive test, like a positive ANA, and then they're exhibiting the symptoms associated with that antibody. They have all the classic symptoms. And so then the rheumatologist would say, you in fact have this specific autoimmune disease. The autoimmune-ish, I would say, or I would say um, autoimmune markers without autoimmunity are people who have, let's say, a positive ANA, but don't have symptoms of lupus or anything else associated with a positive ANA, or they have positive thyroid antibodies, but they actually don't have symptoms of Hashimoto's, or they have, something that is showing up, but they actually don't have the disease process. And I call that, again, autoimmune-ish because it's looking like autoimmunity, but it's actually not. It's the immune system thinking it's fighting something, it's fighting, self, or it's looking like it's fighting self, but it's not actually translating to an actual immune problem or an actual issue. Now, the underlying problem with that, or the thing that may be driving that, is certainly infection, where, there's this mimicry that happens, right? So instead of the body fighting infections, fighting itself, that's certainly one possibility. The other possibility, which I've actually published on, is the fact that there's a condition known as Mast Cell Activation Syndrome, which I do a lot of speaking on, and a lot of my social media is focused on that. What we know about this condition, which is very prevalent in those with vector-borne infections, by the way, what we know is that if that part of the immune system is dysfunctional, it can actually send a signal to the cells that make antibodies to make antibodies that are actually false or mimicking, and they're not actually real antibodies. So you have an ANA, but it's actually not really doing anything. It's just a false signal from already a dysfunctional immune system. And that's why I'm always cautious about people who have weird antibodies and a lot of antibodies. A lot of these patients wind up in a rheumatologist's office, and are told they don't have anything, but they still have a fear like, oh gosh, I don't want to wind up with scleroderma or some of these crazy, really scary autoimmune issues. But they can have these antibodies for years, and they can come and they can go and they can go down and go up. And that's really a sign that it's part of the immune dysfunction as opposed to the true autoimmune disease.
Yeah,
Hope that makes sense.
it does. And I'm glad you brought it up because we just had a couple of weeks ago Dr. Amy Proal on, and she's out of New York City as well,
Yeah.
and she was talking about the molecular mimicry concept as well, which is basically when a pathogen creates these proteins that are similar to the human body, and then the immune system responds to that, right? So that's how she explained it, at least, where molecular mimicry is the bacteria creates a protein, the protein resembles the normal human cell, and therefore the immune system responds to it and it gets confused. Is that a fair way to put it? Or you can be honest. I'm just trying to bridge these together a little bit.
Yes, but I think that's one mechanism and one possibility. And I'm bringing up this other possibility where it's not just molecular mimicry towards the organism, but it actually is the immune system. So let's just say the mast cells are there to help protect you against the environment, infection, etc. And they have a few different functions. They explode and release different chemical mediators in response to infection or assault or toxin. But the other thing they do, and this is the underappreciated thing that they do, is they talk to other parts of the immune system. And so when they're dysfunctional, they're sending a signal to the B cells, hey, make antibodies to A and A. It's almost like presenting like an antigen and saying, hey, yeah, this is bad. But in fact, it may not be due to the organism itself, that antibody production. The mast cells themselves could be overactive because of an underlying infection like Lyme or Bartonella, but what they're presenting to these B cells is that almost like not related to that. It's really just like I think about it as like wires getting crossed. There's just a
Right.
lot of it's a mess, and the body is just like kind of crazily trying to fight
Yep.
very unproductively and making these antibodies.
So how I interpret that is essentially the body is saying develop these antibodies to Lyme disease or another pathogen, even though I have no idea if that even exists in the human body. So it's
Right.
totally just haywire. Hey, I think, go develop an antibody to this crazy virus or this crazy bacteria, but I have no idea if it even exists. I'm just totally making things up and just telling you to do crazy stuff. That's kind of what you're
Yeah.
saying, I think, right?
Yeah, I think that's one piece. But I think there's more to the story, and that's what I was trying to say, is that I think there is
Yep.
also the fact that there is this molecular mimicry concept as well, right? And I
Yep.
think it's maybe a combination in some patients. So I don't want to say it's one or the other. I really think that for a lot of patients, it's probably a combo of both. But to raise a point, a lot of patients in this realm have Epstein-Barr, CMV, HHV6, HHV7, parvovirus, Coxsackie virus, and they're all like sky high antibodies. Do they have all those viruses? Are they truly active in the patient's body? We don't know. Sometimes you can do a PCR test and prove and see, oh, yeah, look at that. The EBV is PCR positive. So that means that that is a truly active viral infection, that the virus has escaped the cell and is replicating. But very often we can't find it. And so then we have to sit there and kind of guess, are these viruses truly active, or is the immune system thinking that it has to fight those
Right.
viruses?
Which is a scenario you described where it's just haywire and is creating things when the actual virus is not there, potentially, right? Because it could be either or. To your point, it's not just one, it could be either or. And it's difficult to tell because sometimes things like Lyme disease exist in low concentrations in the body. So is the Lyme there? We can't find it, but it's not easy to find. Or maybe it's not
Right.
really there, and maybe it's just responding, thinking Lyme's there, but it's not there, and that could be MCAS, right, or haywire immune system, and that's kind of what you're
Yeah.
saying. Is it's really hard for you to tell, which is why it's not an exact science yet. Although you are data driven, there's still more to be, learned in time as far as
Yeah.
the science is concerned to get better tests to identify this black or white scenario that doesn't exist yet.
Right. No, exactly. I mean, my hunch, I can give you what my hunch is, I still think that there are infections that are, whether they're low levels, whether they're high levels, wherever they are in the body, they are impacting the immune system in many ways. And whether it's even, COVID and the spike protein, whether it's, again, these viruses, whether it's mold exposure, mycotoxins, or chronic fungal infections, or chronic parasite infections. I mean, again, I mean, the list goes on, right? I think there's so many things that our bodies are bombarded with all the time. And so I think that there's a component of there's stuff there, right? I would never say to a patient, you don't, you definitely don't have Lyme disease, right? Just because I don't know. I think my point is that I think that a lot of patients have these things, and it causes the immune system to go awry. But the problem is that it's sort of like chicken or the egg in a way, right? Where do we go in and intervene? So for some patients, if I go after their immune system and the immune dysfunction, their body can handle the infections in their body better and maybe push it into hiding and leave it there. Because the reality is, and I say this to my patients all the time, I think we're all harboring things
But yeah.
since childhood. Okay, I use this example. I'll just did try, kind of go in a little different direction for a second, then I'll go back. But I
Yeah.
always tell this patients, I like to use the example of strep. Kid gets strep. They take antibiotics. The pediatrician says, okay, 10 days of antibiotics, and the throat gets better. Kid goes back to school. A month later, winds up with strep again, and the pediatrician says, oh, yeah, it's going around. Yeah, you probably got it again. No, the kid didn't get it again. That was strep that was in the body, in the tonsils, that got reactivated again because when you have strep, again, this is just like a broad generalization.
Yeah.
Let's say you have a million strep bacteria in your throat, and you take antibiotics, and maybe you get it down to 100. At 100, you don't have a sore throat, you feel okay. But from 100, they can go back up to a million, and then you have strep throat again, right? So I think that antibiotics will kill a lot of them, and then the immune system has to kick in and hold it at bay. And if the kid doesn't get enough sleep, eats too much sugar, blah, 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 whatever, then the immune system gets suppressed, and then boom, the infection comes out again. So I think that everyone has strep, everyone has Epstein-Barr, everyone, like generally speaking, right? Not everyone, but a lot of people are carrying these things around. And if their immune system is intact, then they will be able to hold everything at bay and they'll never have manifestations of these conditions, right? So I think a lot of people are walking around with Lyme, Bartonella, Babesia, et cetera, who are asymptomatic. It's when the immune system cannot handle that it comes out, and then that impacts the immune system even more, and it becomes this really vicious cycle. So if I can sometimes go in and help the immune system, I can keep the infection suppressed. I may not even have to go after the infection directly because now I have an immune system that is working correctly and appropriately. Vice
Yeah.
versa, there's some patients that I cannot get their immune system online until I take care of the infections, right? So it's really determining which patient, or what each patient is really like, how they're going to respond to that particular intervention. Like, do you go after it one way or do you go after the other way or both? You know?
Yeah. But I'm curious because we've had another topic we've had on this podcast with doctors is why do some people get sick and others don't?
Yeah.
Husband and wife, mother, daughter, whatever it might be. And some people have argued that it's just we're all bio individual. We have genetics that are expressed differently. We have different weaknesses and vulnerabilities in the human body. Whereas others say that's less of a problem. And it's really just the successive infection trigger, meaning you've been infected with so many things that you eventually hit a point where your body can't manage all the reinfections of the same thing, like multiple Lyme infections,
Mhm.
combined with other infections you acquire over life. Where do you stand on this? Is it really a bio-individual component with genetics and weaknesses in the human itself, right? Or is it the successive infection trigger model, from your standpoint?
I think it's the former. I think it's that there's genetics, bioindividuality. I think there's environmental factors, traumas or early traumas, stressors that alter how the immune system reacts to these various pathogens. I don't think it has to do with load per se, because I have, I take care of a lot of families, multiple family members, and I really should publish on this because it's really fascinating. I have a number of families where it's, again, it's, maybe three of them are sick, two of them aren't, or four are sick, one isn't, or however, whatever way you want to think about it. And so the question is, well, why is it one, let's say one family, four are sick, one isn't. Maybe the husband's fine, the wife isn't, and the kids aren't, or vice versa, or maybe the parents are okay, but the kids aren't. And I think if you really, when I take a really good history, what we start to see is a couple things. One is I think that each successive generation, unfortunately, is a little sicker. And I think that has to do with our real toxic load that we're always being exposed to, right? Whether it's the microplastics, the pesticides, organophosphate pesticides. I mean, it's just a crazy number of things that we're breathing in on a daily basis. The kids are exposed even more than, let's say, my generation, than the generation before us. So it does seem that each successive generation is sicker. I think that's epigenetics, right? So I think there's some genetic vulnerability. And then I think there are epigenetic changes that are happening early on in life that then is setting them up for how their body deals with infections when the infections come on board. Because, again, like if I have a patient in a family who's generally well, sometimes their results look even worse than other people in the family. They have Lyme, Babesia, Bartonella, they have all the infections, and they're really relatively asymptomatic. And they can have a family member who maybe has, maybe just Bart or Barton Babesia or whatever, and it's usually not just one. But sometimes their lives don't even look as bad and they're much sicker. So I think it really has to do not with the load, but really has to do with um, the early life experiences, the exposures, the traumas, and the epigenetics that then sets the stage for how their immune system reacts over time.
Yeah. So let's circle back to addressing the immune dysregulation or the actual pathogen, and it varies from patient to patient. And there's really no, it sounds like from your experience, no right answer. So when it comes to addressing the immune system in that model, what tools do you generally use to regulate the immune system? Whether it's herbs, pharmaceuticals, what specific tools are you using to address that particular component of your patients?
Yeah, so number one, I really want to identify what the immune problem is. In the vast majority, I mean, it's my lens, so I will see a lot of it. It's underlying mast cell activation syndrome, which really is an epigenetic phenomena that is triggered early on in life after, again, some genetic vulnerability and then exposures to various things. And so I like data, so I like to test and see if mast cell activation syndrome is part of their immune problem. And if it is, then I'm going to have a pretty, systematic approach to that. I'm going to look at triggers. I'm going to try to understand beyond, let's say, the infections, what are other triggers that are keeping that immune system dysfunctional? Are they living in mold, or are they being exposed to mold at work or, elsewhere? Are they not getting enough sleep? Is it their diet? Is it they're going through divorce, or there was a death in the family, or right? I'm looking at things that could potentially be making this worse. And sometimes it's like the big stuff that I have to look at, and sometimes it's really at a micro level. Sometimes mast cells are reactive to ingredients in things. So I have patients, for instance, they come to me, they're being treated by another practitioner, and they're on a bunch of herbs and a lot of supplements, and they're really highly reactive. And then we have to go through, like, is there something they're taking? Is it an excipient? Is it magnesium stearate in one of their supplements, or microcrystalline cellulose, or is it a dye in something, medication, or something else? So sometimes it has to be at a really like micro level to really understand what the triggers could be that are keeping that immune system. Ultimately, the infections are going to be a big trigger, but you have to also look at all these other things. I have to look at their nervous system and how their nervous system is impacting their immune system. A lot of patients who have been in this world chronically ill for a long time have limbic dysfunction, They have sympathetic overdrive. They're living in a fight or flight world, like their body is just constantly, fighting. And that's going to, some of that is driven by the dysfunction and the infections, and some of it is vice versa, causing worsening of those things. So, we're talking about limbic retraining. There are a number of programs out there that I like patients to think about, or vagal nerve stimulation. So I'm thinking about, again, resetting nervous system, resetting the immune system. And then, yeah, there are lots of other tools in my toolbox. I have supplements, I have herbs, I have lots of different medications, antihistamines, and many others that can help basically calm down these dysfunctional mast cells so that there's less inflammation happening and so that the immune system can again like really go after the infections appropriately or deal with the infections appropriately. So it's a lot. I think the positive way to look at this for patients who are really struggling and have been at this for a long time, I think there's a lot of hope. And I just always love to, give that message because I see it every day in my practice. It can take time. It is, there are a lot of things that have to be trialed and thought about, but at the same time, that's the good news. There's a lot of things that could be trialed and a lot of options that if you're just stuck in and only looking at the infection alone, you're a little bit more limited, right? You try the herbs, you try dapsone protocol, you try IV antibiotics, you try ozone, there are all these things. I'm not saying they're wrong. We do all those things, but the fact that we also have these tools for working on the immune system, which can make a big difference for a lot of people, right? It should give people hope
Yeah.
that there's still a lot to work on and to help.
Yeah, if somebody listening, Dr. Dempsey, is thinking, hey, I'm doing better, but I still think that I'm MCASy, right? I feel like
Yeah.
I'm still a little, more overactive than I should be from an immune standpoint. Or, hey, my nervous system still seems to be stuck, but I'm doing better. Are there any recommendations you can make, whether it be a limbic system program that they can do at home, or whether it be some sort of supplement they can buy online to help regulate their immune system? What are some easy tips you can recommend to people that are listening that would be meaningful and hopefully helpful in their MCAS and nervous system journeys that they have going on?
I really think that everyone who has a vector-borne infection or some kind of complex chronic inflammatory condition, including long COVID, right? I'm going to throw these all in the mix. If you're struggling with a chronic illness, I think really everybody should do some kind of limbic retraining program. There's no downside other than some cost, but they're relatively inexpensive compared to a lot of other treatments. I really think everyone should be doing that at the very least. Is it going to change everything? Is it going to cure you? Maybe not. But there are some patients who have seen tremendous changes, right? It's not everyone, but some people it's mild changes. For some people, it just allows them to tolerate things a little better so they can do more extensive protocols. But I have patients who've gone from eating three foods and reacting to everything else to being able to eat a lot of foods and not reacting just by doing a limbic retraining program. So to me, that's something that can be done on your own, right? You don't need a practitioner guiding you through that. So that's a no-brainer. Again, it may not be the right thing for you, but again, not a lot of downside. I think also, again, being vigilant and really trying to understand your triggers, I think is really, really key because I have patients who are not getting better. And every time I see them, I always go back over the history again and again, and I always am trying to help them figure out the triggers. A lot of this can be done, people can do on their own, just sort of thinking about, okay, where am I living? What's going on? What are my exposures? And what I find happens a lot is that when people are really sick, it becomes very hard for them to identify the triggers. It's just overwhelming. But the simplest thing, well, maybe not so simple in the long run, but is to really understand your home. What's in your home? Are there VOCs that are being released into the air. Did you just paint your house and they used a paint that had a lot of VOCs, or do some kind of construction that released a lot of dust or other things that you may be reacting to? Could there be mold? And what I find is that for some patients, they're very resistant to that. I have patients who have family members who are contractors, and they say, no way, can't be, my husband's a contractor and he looks everywhere in the house, and it's impossible. Or we've never had water intrusion, we've never had a flood, it's impossible. Um, and I find that more often than not, and the more and more like we dig, the more we realize actually that a lot of patients are living in toxic environments and that are keeping them sick. And so that's one area. It's not easy. It's not an easy solution, but it's a relatively easy thing to try to identify on some level, right? There's some tests you can do on your own. We have a kit that we promote on my website that you can buy and try to test for mold and mycotoxins. I mean, there are things that you can do to try to figure that out. I think that's important. And then, in terms of um, then identifying things that you can try, generally speaking, over-the-counter antihistamines, pretty easy. So patients can try Claritin, try Zyrtec, run through it. Generally, a lot of this can be done on their own. I prefer that they have somebody guiding them through it because there are some nuances and things, but that's pretty easy. There are some natural products that some people find, again, they just want to try it. We have things like the DAO enzyme. We have a product that we sell, Histex, which is has that diamine oxidase enzyme that breaks down histamine in the gut. For some people, histamine is the problem. For some people, histamine isn't the problem. Quercetin is used by a lot of people. It's hit or miss, and sometimes it can cause some issues. There are people who are very sensitive to quercetin. They have a particular genetic problem where they have an enzyme. There's an enzyme called COMT, catecholamine O methyltransferase, and it's an enzyme that breaks down dopamine and other catecholamines, they're called, epinephrine or epinephrine. And in some people, that enzyme is slow, so they have a hard time breaking down. They wind up with like too much dopamine, too much of this, and that stimulates the nervous system, so it makes them actually more anxious and they don't feel well. And quercetin slows that enzyme down even more, so it can cause even more anxiety and more stimulation. And so if people try quercetin, they don't know what their genetics are, and they try it and they don't feel well, don't push through it. It's not going to work. It's probably not the right thing for you. But for some people, quercetin is a great antihistamine and mast cell stabilizer. Luteolin, and there are a few others on the market that have some mast cell stabilizing properties. I mean, the list is long. When I give lectures at conferences, I have the slide. There are at least 30 things on that slide or more. I have a slide for natural products, and I have a slide for pharmaceutical products. I mean, there's a lot to try. Ideally, again, I think some things people can try on their own. Ideally, they find a partner that can help them work through this.
Yeah. Yeah, and that was excellent. There's a ton of information. Now, when it comes to actually killing the pathogens from that approach, now if the immune support isn't working and you pivot and you want to now target the pathogens, the Lyme,
Yeah.
what are you doing from that standpoint? Are you using traditional antibiotics? Are you doing herbals? What are some tools that you're using that you're finding success with that side of the treatment approach?
I do a lot of different things because I really believe in personalized medicine, and every patient I see is different than the patient before. So I can't stick to the same protocol for every single person, even though that's what people want. And everyone, when I train other doctors, they want that algorithm. Okay, if they have this, you treat them this way. And if they have that, in medicine, there are algorithms. If people come into the ER with a heart attack, you always do the same thing. And it's impossible. But I use herbs a lot. I love herbal medicine for the right patient, for depending on what you're trying to do. Often I combine herbs with other things that I do. I will sometimes use antibiotics. I minimize the amount of antibiotics I use though, and I really try to um, select the patient that I think really maybe has maybe failed a lot of other treatments, and then maybe I'll go to antibiotics. Well, I will. Well, let me preface that by saying acute infections need antibiotics. That's not what we're debating. I'm talking about more of the chronic infections, people who have tried many antibiotics over the course of many years, right? May not be, antibiotics again may not be right for them. There may be some promise to the dapsone protocol or high dose dapsone protocol. So I do utilize that. Again, selecting the right patient, and I have seen some good results, but I think it really, again, has to be the right patient for that. And then I utilize a lot of other treatments, ozone therapy, phosphatidylcholine, IV PC or PK protocol, however you want to look at it. I have my own, we'll call it the Dempsey protocol because I've changed it up a bit. Um, but I find that, helpful, can be supportive, can be helpful for the infection. It's not fighting the infection directly, but it's helping stabilize mast cells, and it's helping stabilize the immune system in a way. It's stabilizing cells, it's rebuilding cells, it's healing. So I have a lot of tools that I can use, IV. We'll do things like IV methylene blue. We'll use, I'm probably forgetting a lot of things. We use a lot of therapeutic plasma exchange or plasmapheresis, which I think has been really very, very interesting in patients with infection. I don't know. I'll try to give a little background on plasmapheresis or therapeutic plasma exchange. Essentially, it's where we pull out blood, we separate the blood into various components, and we take out the plasma part, and we put the rest of the blood back, and we give that blood back along with albumin and some fluids. The thing we're taking out, the plasma, is where your antibodies are. And so for patients who have a lot of these bad antibodies or mimicking antibodies or antibodies that are not doing the right thing, you can take that out through plasmapheresis. You can also remove biofilms that are abundant in the plasma. Biofilms are a big issue. We didn't even cover it yet, but that's also often a reason why people are not getting better. So you can remove biofilm, you remove a lot of the cytokines and the inflammatory molecules that are being released into the blood, into the plasma. You can remove plastic and microplastics. You can remove heavy metals. You can remove mycotoxins. And we're doing some studies on all this. So this is all, we have some studies supporting that we're removing these things. We need to do more. But I think while we're removing all that, we're probably removing some load of infection that may be in the blood at that time. And what I think that TPE does for people, that's short for therapeutic plasma exchange, I think it sort of cleans their system out, and they do a number of them depending, it could be 4 treatments like this, could be 6. I think it's allowing us to then go in with the appropriate treatments, and then we have better success. So what we combine it with very often is a therapy called SOT therapy, supportive oligonucleotide technique. That's really one of my favorite treatments because it is targeting the molecular targeted treatment. Less side effects, better for patients who are more reactive. Um, and um, and I can go into the specifics of it, but if I clean their blood out and I remove a lot of that uh, gunk, all that toxin stuff, the biofilms, the plastics, all that stuff, and then the body's in better shape, and then I can go in and give the targeted therapy for Bartonella or Lyme or Epstein-Barr or Babesia or whatever. Um, I think that we're starting to see that that's actually we're getting a little bit more um, um, what's the word I'm looking for? Not, yeah, like better results and more
Yeah.
lasting results, I would say.
Yeah,
Okay.
sustainable, more sustainable results.
Sustainable. Thank you.
And
Thank you.
it's interesting because one of the biggest things we hear about SOT is, and I think it's a great tool. Everybody who's used it that has shared it with us has had great, success with it. But the feedback we always get is, hey, if you're doing SOT, you're just doing very targeted treatment for a particular type of Lyme, a particular type of Bartonella, a particular type of whatever it is. But oftentimes in chronic Lyme patients, we have probably dozens of active infections. We're only targeting three. So what are we really doing, right? And then the answer to that generally that I have is, hey, well, sometimes it just takes knocking down a couple of the things that are keeping you chronically ill to allow the body to be strong enough to fight back the others to have a homeostasis, state in your body to maintain health again. So what are your thoughts on that? Because SOT works pretty well, but then we've heard some people be critics of it, and some people say
Yeah.
that it's not the ideal tool because they may feel good for 6 months or a year, but then they get sick again potentially.
Yeah. So I hear that. I hear that argument. But I have some amazing cases that I don't think I could have achieved without the SOT therapy. And those patients will say what why the SOT has worked for them, and I agree with this, is because we've been persistent with it. So let me give you an example. Let's say you do one set of tests and you have Borrelia burgdorferi, which is Lyme. You have Babesia, let's say Oda coli, and you have Bartonella henselae. And so you do a round of SOTs for each of those and you lower the load. But you might not get better because the load is still high because there are other strains there. There are other things there, right? So, yeah, so some patients will say, they'll do one, they may get a little relief for a few months, and then they're flaring again. And they go, oh, what's happening? I said, well, you only did one SOT. Like, that's not enough. You got to keep going, right? So the patients that we've done, let's say, we'll do those three, and then we'll test again. And then we see, oh, they're still all positive. Now they need another round of those three strains. But then maybe I have to test and see if they have Bartonella quintana and Bartonella vinsoni, Bartonella elizabethae. Excuse me, and then they may need SOTs for those. And then maybe they have Borrelia miyamotoi and they have Babesia microti and Duncani. And so it can be, so the downside is that it can be expensive to do all those treatments. But the patients who do the best are the ones where we're persistently and consistently testing, giving the SOT, testing, giving the SOT, while supporting the immune system, of course, while doing other things. Sometimes in the interim, we have to do a round of herbs. Sometimes in the interim, we have to do a round of antiparasitics. We have to do a round, like there are different things that happen that we realize maybe keeping them sick, and so we have to go in and work on it. But I think the error that a lot of people make who are using SOT are really just they're relying on, like a one-time treatment or two-time treatment. But Lyme, like each strain may need two or three minimum SOT treatments over the course of a year, 2 years, or whatever. So, I have this one patient where we've been doing SOTs now probably for 3 or 4 years, maybe a little longer. And she started with a flare that was very neuropsych driven, probably in the realm of PANS. Probably starting, she was probably around 18. But I've been treating her off and on over the years. But the worst flare came like started like right as she was going to college. Really severe neuropsych stuff, severe GI symptoms. We knew she had mast cell activation syndrome. And we actually tried a short course of antibiotics just to quiet things down and didn't really touch her. And then we started more aggressive on the mast cell and then started going after the SOTs. And each round of SOTs she did, you could see the load being lowered. You can see the new baseline that we would establish. And she's had to do multiple strains of Babesia, multiple strains of Bartonella. And for her, what we realized is Babesia is really actually the thing that makes the biggest difference. Every time we do another Babesia SOT in a different strain, she achieves a new baseline. Now she's a senior in college. She's doing amazing. We didn't even know if she would be able to finish college. She had so many issues. And she's thriving. I talked to her mother the other day, actually, and she was filling me in on. She said this is like a miracle case, and I've asked her to actually maybe write up the case, maybe even present her at a. I've presented her case at different conferences, but I actually want the patient to come and do a presentation with me because that's where that's where you see the results. She's been very open to the SOT. She sees how she feels. She knows she's had some bad flares, but we just keep working on it and we keep lowering the load so that again the new baseline is achieved. And her baseline now is amazing. No
That's great.
neuropsych symptoms. She's off of all psych drugs, and she was on quite a few per her psychiatrist. Now she has none.
That's wild. That's amazing. So again, hope. This all comes back to hope because
Yeah.
people listening saying, I'm never going to get better. Well, look at that, right?
Yes.
I want to dive a little bit deeper because oftentimes we get, and a lot of the questions I'm asking are driven by just community feedback and questions from listening to past podcasts. So one of the things that is always hard to tell is, hey, I've had Lyme disease and co-infections. I've done a lot to treat, but I still have a lot of inflammation, a lot of pain, a lot of some, on and off neurological stuff going on. But I'm not sure if it's just MCAS or if it's still an active, persistent infection. So what are your thoughts that is it possible somebody can have Lyme trigger MCAS? They address the Lyme, but the MCAS persists, and they have to address that. Or generally go hand in hand when the Lyme and the co-infections get knocked down, that the MCAS will resolve itself. How does that work?
That is a really great question. I'm so glad you asked that because that's an area where I think there's a lot of misunderstanding. Um, the mast cells, so I would say the vast majority of people, this kind of goes back to what I said earlier. Vast majority of people already had a altered immune system when they're exposed to Lyme. For the most part, there are some exceptions, but what I would say is that this is primary mast cell activation syndrome. They had these early childhood exposures of various things, some epigenetic changes, then they get exposed to Lyme, then BART, then something else. And so the mast cell piece was there, and it just keeps getting worse with every exposure. And now everything is activated, right? And so a lot of people in this community believe that what this is, in fact, is secondary mast cell activation syndrome. And what they believe is that these are people that the infection is purely the driver of their mast cells. And if you cure the infection, the mast cells are going to go back to normal. That's secondary. Primary is your mast cells are not great. You get the infections, they get worse. You treat the infections. There's still mast cell activation syndrome there. It may be better, but it's not gone because they were already dysfunctional before the infection. This is by far the most common thing we see. Secondary mast cell activation syndrome is very, very rare. I've actually never seen it. Never. Meaning that this is a patient where, again, we treat the Lyme and their mast cell disease goes away 100% and they never have it again. I've just never seen it because the mast cells were dysfunctional. The infection keeps driving it, the mold, the stressors in their life, all this stuff keeps driving it. You lower the load, there's a little bit of relief. The mast cells can calm down and they can be quiet for a while, but they can come back and be reactive again because they're not normal mast cells. They're
And
already at those
they can come back this without an active, persistent high Lyme infection. I think you're saying, correct?
yes,
Okay.
yes, exactly. But usually there is some trigger. It could be the Lyme coming back, right? It could be that the Lyme was suppressed and it reactivated, or one of the other infections reactivated. It could be a new infection. They get exposed to COVID, right? The infections were quiet. They were in remission, we'll say. Then they get a new infection, COVID or some other viral thing. And then maybe there's a lot of reactivation happening, and now their mast cells are a mess. But the mast cells already, when I say dysfunctional mast cells, what I mean is that they, at their baseline, are leaky. These are leaky mast cells that are leaking cytokines, inflammatory chemicals that cause baseline inflammation. So patients with mast cell activation syndrome have inflammation always, whether they know it or not, right? Sometimes the inflammation is so minimal that actually they feel pretty good, but sometimes not. So that baseline, there's inflammation. And then when these mast cells get more activated, they release more inflammatory cytokines and inflammatory chemicals, and then that brings this to a head, makes it worse. So when you treat the Lyme and you get rid of the load, the mast cells can go back to that baseline, but they don't go back to totally normal where they're just sitting around. Normal mast cells are in people who have the mast cells are there. Everyone has mast cells, um, but they're sitting quiet. They're not leaking. They're quiet and they're just waiting for an attack. If they get exposed to COVID or they get exposed to some toxin or something, they'll react. And then when they're done reacting, they go back to their baseline, which is basically like nothing. They're not doing anything. And they just wait for the next attack. People with mast cell activation syndrome are always in that state of their baseline is not nothing. Their baseline is always a little higher. And over time, the baseline does seem to go up and up. So what I say to people, again, this is not to make people upset, worried about this. It's just that if they if you treat the Lyme and the mast cell persists or recurs, it could be Lyme reactivation, could be some other trigger. Um, that wouldn't be shocking to me, and it would mean that you got to go in and you got to deal with the mast cell, but you always have to look at the triggers. So could the Lyme have reactivated? Is this long COVID? Is this mold? Is there some other trigger? And you try to eliminate the triggers and you try to stabilize the mast cells the best that you can. They're never going to be perfect, but they're going to be better. And they can go slightly more quiet than they are when they're active. And so then people can be, really highly functional. Like again, there are people who have underlying mast cell disease, but are really pretty asymptomatic until it flares. So does that answer your
It
question?
does. And just from, the community feedback and just talking to so many patients in the community, I think so. You did a great job at explaining that. That was wonderful. And all the triggers, right? Reactivation of Lyme. It could be COVID. It could be mold. It could be all kinds of things. But one patient story comes to mind. Jesse Rubin, who is a beautiful, beautiful artist and has all kinds of songs out about Lyme disease. And his story that we just published a couple of months ago was he addressed the Lyme, but he kept having these flare ups and these relapses with MCAS like symptoms. And he told us that he didn't realize how overstimulated he was with his nervous system until he did a ketamine treatment. And after ketamine, he was so normal, like he felt like pure. And he said that nervous system reset and that mind reset allowed his body to be at such a resting and calm state, which then all of that overactiveness he believes from his immune system was brought down as well. So I wonder, in addition to infections, Lyme, COVID, toxins like mold, could our nervous system be triggering a high level of MCAS as well? And is that something that you think is pretty prominent in our community?
Yeah, and I think it goes back to what I said earlier, is that one key to getting mast cells better is to go after the nervous system. But I think it goes both ways because the the mast cells are really abundant in the nervous system and they line all the neurons in the body, all those nerves that are like, I think about it like, you have a wire, right? And you have and it sends a signal, right? Electrical signal. That's like a nerve in your body. And the mast cells literally like cover and align every nerve in the body and in the brain. And when there's a signal that the mast cell gets that there's danger and they release their inflammatory chemicals, they send that signal to that neuron, that nerve, and they say, danger, right? The nerve will then produce its own set of neurotransmitters and even something called substance P, which we know is something that causes pain, substance P for pain, um, which can drive pain syndromes in patients with mast cell activation syndrome. Um, but it can release a number of other neurotransmitters. Then that sends a signal to the mast cell that there's continuous danger. And then it becomes this vicious cycle where the mast cells are irritating the nerves and the nerves are irritating the mast cells. And then you've got to break that cycle. So sometimes it's you go after the mast cell and that calms the nervous system down. So sometimes we give an intervention for the mast cell and patients will say their anxiety, their depression, OCD, whatever their neurologic manifestation is, gets better. We've targeted the mast cells and their nervous system can now relax. Sometimes you have to do it from the other angle, right? The nervous system has to be addressed in order for the mast cells to understand that there really isn't danger. And so you can go after the nervous system side, right, through limbic retraining, which we talked about, ketamine, which is another way to go after it. Um, what's the other thing I was just thinking about? It's an injection. I don't know, all of a sudden I just
I
blanked.
don't know.
Um,
Yeah, well, it'll come back to you, but I'm curious
yeah, yeah, yeah.
because there's a lot of neuroplasticity programs out there, and we've had a lot of
Yeah,
the leaders on this podcast. Is there, and it's okay, we're not going to be throwing shade to anybody, but if you had to recommend ones that you support and you have experience with, what
yeah,
would be some programs that you fall behind? Because like we love Dr. Kathleen King and Primal Trust. She was
yeah.
fantastic when she came on. But again, everybody's different, right? So I understand that. But what are some that you can throw out there for people that are different programs they can look into from a neuroplasticity and a brain retraining standpoint to help calm down their nervous system if they feel overwhelmed and in fight or flight and doom and gloom? What are some specific targeted programs you can recommend?
Yeah, so on my website, Dr. Tanya Dempsey, I have a resources tab, and under that I have products I love. And I have all like the programs that I like, and I have various things that people can look at and check out. So I recommend that page because that's all things that I've vetted myself. Primal Trust is on that list. So I love Primal Trust, particularly for people who have a lot of trauma. I think it's a really great trauma-based program. So that's one that's become a favorite of a lot of my patients. And I would say Gupta is
Yeah.
the other one that I really, really like. They're just different, right? And what I say to patients is go on their websites, read about it, see what resonates with you, and see which one, is gonna, maybe again be the one that you're gonna stick to and be most consistent with. There are other programs out there, and I keep hearing about more. And off the top of my head, I can't remember all of them, but those are the two that are like my go-tos for patients to do limbic retraining. I love the Apollo Neuro for more of like the vagal stuff and more of like sympathetic resetting. I think it can be really great, a great tool that they wear, right? That's like a wearable thing. I like certain types of vagal stimulators because sometimes the issue with the nervous system is that the vagal nerve um, which is really like the main part of the parasympathetic nervous system, right? It's really what's like helping with rest and digest, um, is really what's weak. And so it's not just calming down the sympathetic nervous system, but you got to get the parasympathetics up. So sometimes vagal nerve stimulation is helpful. I think that there are some products on the market that I think are not great or they don't really work, and there's some that are better. So I'm still trying to figure out, which one is really going to be the best for most of my patients. But again, like those are things that people can do, on their own, in their own time, right? So I like those things. But then there are more aggressive ways to treat the nervous system. Like you said, like ketamine, which isn't, can be done IV, can be done intranasally, can be done with a lozenge, which can be done, and then usually there's some kind of therapy or support that's going on at the same time because it's a very vulnerable time when people use ketamine. You want to sort of like reset your thoughts and the way you remember things. There are other um, things that what do we say, psychoactive compounds that people want to explore, like microdosing,
Yeah.
of psilocybin, which seems also very interesting. and maybe resetting the nervous system as well. So those,
Yeah, there's a lot out there. I mean, there's a lot.
yeah,
I do want to. There's two things I don't want to forget to circle back to. One of them was biofilm because
yeah.
it's such it's and again it's something we've had conversations with various doctors about, and some feel and some have definitively told us biofilm is not that big of a deal. People got to chill out, right? And that's me paraphrasing. That's basically what they're saying is like it's not that big of a deal, right?
Yeah.
Others are saying like it is super critical. It's this protective film. The Lyme bacteria, the other tick-borne infections, other viruses come together. They form this protective glob. They exchange DNA. They become this super protective thing, keeping you sick. And you got to break that biofilm. And you got to, when you break it, it's going to come out, and you might get a little sick. And you got to then support the immune system to kill it. But you got to do it, or you're never going to get better. So we've had like two extremes, right? Where do you
Mhm.
fit in that discussion? Because I think it's definitely an important factor. But how important is it?
I think it's I think it's critical, and I think we don't even understand the biofilms themselves. There are different types of biofilms. There's more and more research being done to try to understand what is stabilizing those biofilms and really preventing the infections from being able to be treated, right, while they're in the biofilms. We have biofilms everywhere. We have them in our nasal cavities and sinuses. We have them in our bloodstream. We have them in our gut. So some of it is normal. Some of it is just a result of, us being humans and being exposed to a lot of things. But there's no question in patients who are chronically sick, the biofilms are playing a role and are going to make it more difficult to fight infection. And so I think most of my colleagues in ILADS, so if we, talk about, I love, I have to give a little plug because I'm on the board, I'm secretary. So I was just elected as secretary of, so I'm on the executive board of ILADS.
Congratulations.
Thank you. Thank you. And I'm really excited about the work that we're doing. I think those of us within ILADS understand that the biofilms have to be addressed on some level. What I love about uh, TPE or therapeutic plasma exchange is that that's a really great way to help remove biofilms, especially when the traditional ways like lumbrokinase, nattokinase, and some other things are not effective enough. Ozone can help destroy
Yep.
biofilms. But I think that there are some people who are definitely more prone to what we'll call more resistant biofilms. Um, I think that there was a talk at last year's ILADS conference on something called zDNA, which is like an extracellular form of DNA, which actually forms the biofilm matrix structure. And apparently, that is actually something that is making these biofilms even more protective of bacteria. And so there's some look at, I guess they're doing some research on how to attack this zDNA and how to, again, break down these biofilms. Because again, a biofilm is really a place where it's like nice and warm and cozy, and these organisms can thrive and be protected. And so you could put all the antibiotics in the world, you can do SOT, you can do a lot of things, but if you can't reach that reservoir of bacteria that's hiding, then you're never really going to get a handle on infections. That's how I look at it.
Yeah. Yeah, I love that. So the one thing that Rich told me I had to get into with you, and I've been waiting for this one question because it's
Okay.
super interesting, is the GLP-1 and
Yeah.
MCAS research you've been doing. Because I want to be real, nobody's doing the kind of work you're doing with this. And Rich gave me a teaser when he saw you at iLads, what you share with him, and it just blew me away. So you gotta tell us because nobody's doing this kind of work, and I think this is going to be transformational. And I think there's a ton of potential benefits to this that are going to come out in the next year based on your work. So you got to give us the details on where you're at and the latest and greatest that you're currently finding.
Thank you. Yeah, this is really, really like mind blowing. I'm so proud of the work that we're doing. We published this paper the utility of GLP-1 receptor agonists in mast cell activation syndrome. It's the title of the paper. I was a co-author with several other colleagues. We used 47 patients in the case series, reviewing the effect on essentially microdosing for the majority of patients, GLP-1s, primarily tirzepatide, but some patients were on semaglutide. And just for the distinction of the audience, if in case they don't know, semaglutide is Ozempic or Wegovy, and that's the generic name. Tirzepatide is in what's called Mounjaro or Zepbound. And so we used either one. Primarily, we're starting to use more of the tirzepatide because it's a dual incretin. So it has GIP receptor activity and GLP. That combination seems to be have less side effects and probably a little bit better mast cell stabilization. The mast cells have receptors on their surface for these drugs. So again, these drugs were developed for obesity and diabetes, essentially. Actually, first for diabetes,
Yep.
and then additional FDA approval for obesity, because we started realizing that those with diabetes were losing weight, right? So again, it started out like that. There was a lot of, and still is a lot of backlash to these drugs. I was watching this video the other day with Mark Hyman and Chris Cuomo, basically, kind of, I think it was a little bit of like clickbait, and it was a little bit like, oh my God, these drugs are so bad and people are having terrible side effects. And I couldn't resist, commenting on this video, like, hey, did you read my study? Let's talk about this because every drug, everything out there, right? There's always risk benefits. Yes, if you're using the highest dosage of Ozempic or Mounjaro, and you've lost, 50, 60, 100 pounds, and your skin is sagging, and you've lost muscle mass, and you're not eating well, yeah, it may not be a good drug, from that perspective. But if you have doctors like myself who are monitoring very, very carefully, making sure that patients are eating appropriate protein, maintaining their muscle mass. There's a lot of like we use tools to measure muscle mass. We have something called a body stat. We measure fat, we measure muscle, we measure lean body mass, all these things. So we make sure that we're following everything. When you use these drugs appropriately, they have incredible immune modulating properties and inflammatory modulating properties. So again, what happened initially was I had a number of patients who had diabetes or obesity, and we started using these drugs. I'm just treating because I treat a lot of patients, who are maybe not Lyme patients or mast cell patients. So it was just started using them. And some of these patients did have underlying mast cell stuff. And at my first patient who had obesity and MCAS and underlying and a history of Lyme in the past, I put her on the drug because she's really, really struggling, couldn't lose weight. And the first thing she said after like a month on the drug was that she never had so much cognitive clarity ever. Like her brain was working like it never had. And this is a patient with significant traumatic brain injury, really a significantly long history of Lyme. Again, successfully treated, but then still had that lingering, very, very bright woman, but still has that lingering some word finding issues, some memory issues. And she said within a few doses, again, and that was not my intention with her. My intention was I just wanted her to lose weight. What she said was, I'm not losing weight, but my brain feels so good. I don't care if I never lose weight.
Wow.
I never want to go off this drug, right? So that was the first clue that it was doing something anti-inflammatory. So then I started, trialing it in other patients who, maybe didn't have a lot of weight to lose or didn't have any weight to lose, but had some cognitive dysfunction, had some inflammatory symptoms, joint pain, muscle pain, uh, even gut issues. We always say, oh, you got to be careful with these drugs because they cause gastroparesis or they slow down the gut motility. Then we started seeing that some patients, their gut symptoms started to get better on these drugs. because our mast cells started to get better, right? And we started to realize that the mechanism of these drugs are that they're binding the mast cell and sending a signal like all is well in the world. So stop fighting, stop releasing all your inflammatory chemicals. And so people start to notice the reduction of symptoms. And in some patients within the first dosage.
Wow.
And that's what was really, really incredible. Patients with significant pain, who, we've tried a lot of things and we're treating their Lyme and Bartonella and we're treating their mast cell, and I can't find anything that reduces their pain, even though I've tried a lot of other things that should help with pain. And then within one dosage or two dosages of a GLP-1, again, micro dosing. A lot of these patients do not need to lose weight. So we're very careful with the dosing. Um, all of a sudden pain is starting to, feel better. They're starting to feel better. They're starting to feel their mood shifts, their anxiety shifts. The number of symptoms that we included in this paper, there's a chart in that paper that really goes through each patient, and I think it's in a appendix or a supplemental form where we go through the differences and the changes that each patient exhibited with these drugs, is really remarkable. So even since the publication of that paper, I have so many more patients. So we're gonna publish another paper on our additional findings. And I think that as soon as the next generation of GLP-1 receptor agonists is formally approved, which is retatrutide, which is a triple agonist. So it has three different mechanisms. Then I think we're going to have more data to understand whether that's maybe potentially even better. We don't know yet. Could it be better than what we have already on the market? So the way I look at it is that it's not for everybody. Everybody has to be screened appropriately. So I'm making it sound like a miraculous tool, but what I would say is that, again, it's right for some, not right for others. But in the patients that we've used it in, we've actually not seen as many side effects as reported um, in people who are using high doses of it for weight loss. We're seeing a different set of symptoms and side effects, much less. We're seeing, in fact, what I think is really fascinating in some patients, increased muscle mass.
Really? But that's like the opposite of what you'd expect, correct?
Exactly.
Huh.
And I'll tell you what I attribute that to. I attribute that to the fact that some of the loss of muscle mass in some patients, like mast cell patients, Lyme patients, often have difficulty building muscle, keeping muscle on. Their body's just, the mitochondria are not functioning well. Their body's having a hard time. Their hormones are all disrupted. I think the GLP-1 is actually helping on some level, maybe the mitochondria, maybe the ability for the immune system to stop fighting, and now the muscle mass can actually stay and build. But also, I'm very aggressive with the patient's diet, constantly emphasizing adequate protein to maintain muscle mass. They have to do some kind of strength training, even in patients who have POTS, have symptoms that, prevent them from exercising. We have to find ways for them to move their body so that they can maintain the muscle and not lose it. And I would say, again, 95% or more of my patients have either maintained the muscle or actually improved their muscle mass on these
Wow. That
drugs.
is so what are some of the side effects? Because obviously people are familiar with this drug. It's very popular now.
Yeah.
But in a microdose, which is very small compared to the dose being used for weight loss, what are some of the side effects you're seeing? And when you said it's not for everybody, what subset of your patient population is not benefiting from it? And are there any patterns you can share with our listeners for the subset of people who will benefit versus will not benefit from this?
Yeah, that's such a great question. The last part, I'm still trying to figure this out. And that's the challenge, is there really isn't a marker, a symptom that it really helps me determine, is this the patient that I shouldn't try a GLP-1 in or should try it? I don't know. I don't know how to identify those patients. I would say that the main side effects tend to be GI. And as I said, there are patients with GI issues who seem to actually get some relief And I think that's through their mast cell. So if their GI
Yeah.
issues are mast cell driven and the mast cells are calmed down because of this, they are better. There are definitely a subset of patients whose GI symptoms get worse with it.
Hmm.
So I have two or three patients. Again, I have probably hundreds of patients at this point that we're treating with it. But, I have two or three that have maybe vomiting after a dose, like a day later or 2 days, and not consistently, but just, sometimes even at a low dose, it seems to irritate things. And so they maybe get a little gastroparesis flare. Some patients have to stop it if it's really bothersome. And so I would say that's the main thing is the digestion
Hmm.
for a subset. Again, some people getting better. The other symptoms on occasion, again, this is maybe like one patient had an issue with one of them, like tirzepatide caused more mood issues and a little bit more depression.
Hmm.
But semaglutide actually helped her depression. So sometimes we will see some variability from one to the other. And that's why you really need to, practice personalized precision medicine because you just have to, again, talk to the patients, try to figure it out, see if they're willing to try something else. And again, sometimes it's not going to be helpful. Sometimes we struggle with the dosing. What I find is there is a subset of patients, or there are a subset of patients that need escalating dosages. So they get a great result, like the first couple of doses. They're like, oh my God, this is amazing. Then they do it for a month or two, and then they notice it's not working the same way. So then we increase it. And then maybe they get a little relief again, and then it wears off again. And so those are the patients that we're trying to figure out what's really going on. Is this part of their mast cell thing? And their mast cells are constantly figuring out how to like be stronger and resist it? Or is it a receptor issue or an antibody issue? There's some talk that there's a subset of patients who are creating antibodies, and this goes back to maybe our earlier
Yep.
conversation. They're
Yep.
making antibodies to the drug, and it's essentially binding the receptors and blocking the ability for the drug to bind those receptors to send the signal that it's supposed to send. So
Hmm.
that is challenging, and we're trying to figure out, these people who should be pulsed, maybe you put them on it and then you have to take them off it for a little bit, let their antibodies come down and their receptors reset and do it again. So I think there's still a lot to learn, and again, I'm committed to doing the research and publishing on it. I do want to mention one thing that I don't think we talk about enough, and that is that, yes, these are drugs that are increasing GLP-1 activity that we know suppresses appetite, helps with decreasing what do you call it, like the food noise.
Yep.
Those are all things that a lot of these patients find troublesome. We know that insulin resistance is very common in mast cell activation syndrome and in patients who have infections. And this definitely will stabilize blood sugar and insulin. And again, it stabilizes the diet. So there's a lot of things that this does at a mast cell level and then maybe at a greater endocrine level. But we have other tools. So for patients who can't tolerate drugs, we have other ways to increase GLP-1 activity.
Huh?
We have diet and we have herbal and supplement options.
Get out of here. I did not know any of that.
Yeah, yeah. So
Huh.
we have a product on our store that's called Optimum GLP-1 that has a number of herbs that have been shown to have in combination some GLP-1 activity. And so I have patients who are doing really well on that because it doesn't cause the same GI side effects that the drugs cause, but it does suppress the appetite and it can help with some of the food noise and it can help with some of the inflammation. It may not be as potent. There's another product that we sell called Calicurb, which is a compound that has also this GLP-1 activity, which is really exciting as well. And I've had patients who have actually been able to lose weight with the supplements if they need weight loss, or again, maybe to even stabilize the immune system. But I think diet is a really big piece as well. And higher protein diets, carnivore-like diets. A lot of people know I'm a carnivore. Um, uh, so eating more animal-based protein does seem to stimulate GLP-1 and help with appetite control and suppression. It doesn't mean you have to only eat meat, but in general, eating more protein and protein with good fat does seem to stimulate that GLP-1 activity.
Hmm, interesting. And that's what's even more interesting is when I started looking into this in preparation of this interview, and then the internet knows everything you do, and I open up TikTok and I see an overwhelming amount of autoimmune patients on TikTok saying,
Mhm.
"Hey, I started a GLP-1, Ozempic, whatever it might be, and the unexpected benefit was my autoimmune symptoms either
Yeah,
significantly decreased or
yeah,
disappeared. So I'm getting weight loss and basically this, some people call it a magic cure. Some people were just saying like they've done everything. And
yeah.
it was pretty consistent that these stories kept coming up on TikTok. But then I read the comments to see how people were responding. And a large percentage of the comments were saying, hey, same effects for me. There's more here. We have to let people know about this. Rheumatologists have to know, doctors have to know. And then from a risk standpoint, some people were just saying, hey, you know what? It didn't really do it for me. But that was a smaller percentage. Honestly, it was an overwhelming amount of comments saying it did the same for me. It
Wow.
helped me greatly with my autoimmune journey, which ties back to the whole discussion we had earlier. Like you said, true autoimmunity versus autoimmune-ish, right? But I think in the end, if it's helping decrease the mast cell activation syndrome, a lot of these autoimmune diseases that people have may really just be tied to mast cell activation syndrome. And they're getting this great relief because we don't really know, especially doctors who don't fully understand MCAS, we don't really know what's at the root of a lot of these autoimmune conditions, quote unquote, right? Whether it be lupus, whether it be, an unknown autoimmune disease. People are on all these drugs and especially steroids, which are now weakening the immune system and allowing these bacteria to flourish, having this negative effect by allowing microbes to flourish. A GLP-1 could help calm down the mast cells, but not impact the immune system in a way where it's going to hurt us with bacteria, right? So that's the kind of feedback I had, and I think this is a very promising area. And I think so your study, we're going to put it in the show notes. We're going to link to your study in the show notes, and that's called the utility of GLP-1 receptor agonist and mast cell activation syndrome, which is by you. I think it was Lawrence Afrin, right? Leonard
Right.
Weinstock, and a few
Like that.
others.
Yeah.
So that's awesome. But is this
Thank
something
you.
that rheumatologists and other doctors are starting to use as an off-label tool to help their autoimmune patients, or is that still not really happening yet? It's kind of just doctors like yourself that are willing to be brave to try it and see what happens.
I don't know. I mean, I certainly see some doctors on social media talking about using it and starting to talk about the inflammation. I was sort of honored one of this allergist who has a big following on Instagram actually reported on put the study up and started talking about how excited he is about it. He's not really a mast cell person, but he seems to be interested in it. He talks about it at times. So I saw that and I thought, all right, here's a doctor who is going to start to promote it, and maybe there are others. So I think it's a small community of doctors who are willing to think outside the box, willing to try things outside the box. For there are going to definitely be a lot of conventional doctors who are very uncomfortable prescribing off-label. This is
Yeah.
off-label prescribing, right? So I am still thinking that we need more papers out there, more studies, more research, because these are docs who want quote unquote evidence-based medicine, and the evidence is still not enough to convince them because all they can see is, danger, danger, danger. I also worry about, some of the functional medicine, integrative medicine community because there's often been a little bit of negative um, connotation to medications in that community, right? That they want to rely on herbs and supplements and, getting to the root cause, which is all great, and that's what I do too. But that fear mongering a little bit on, oh yeah, these drugs, these people are on these drugs, and as I'm hearing a little bit of that coming from the functional medicine community, not across the board, but selectively. I think we have to be careful, and I need I need practitioners out there, whether they're integrative, functional, or not, to just be able to step back and look at like how can we help patients? We have to be careful that we're not rigid in our outlook of things, like always doing it. We can only do it this way. We can only use herbs. We can only do it this way, right?
Yep.
This has been our problem in medicine, regardless of what camp you're in. And I just think that we need to be able to look at everything and use it selectively for the right patients, right? This is again precision medicine at its best. So I have concerns on both sides. But hopefully, again, the more we talk about it, the more we get it out there. I mean, hopefully, from this podcast alone, we'll get some traction, and
Yep.
maybe people will start listening, and maybe they'll, send this podcast to their rheumatologist, and maybe an endocrinologist, and maybe somebody else, and so maybe we'll get more, more um, I don't know, more people on board, really.
Yeah, and look, as a board member of ILADS, the International Lyme and Associated Disease Society, one of the core missions of ILADS is to educate and train other doctors.
Yeah,
So I'm assuming, and you can correct me if I'm wrong, that if we want to share this, if our listeners want to share this with their doctors, rheumatologists, primary care doctors, whoever, neurologists, doesn't even matter, and they're interested to learn more about these things, can they contact ILADS and request to speak to you or a practitioner who understands this to learn and potentially, learn from you to try this on their patients? Is that something that could happen?
absolutely, absolutely. And yeah, my mission, in addition to ILA's mission, is really to educate and to teach. We've got to get the message out there. And so that's why I speak. I'm going to be speaking on this topic for an ILA's conference out in the UK, in London. So kind of spread the word internationally. I
Yeah.
just spoke about this at the ILADS annual conference in October. Hopefully by next year, I'll have more data that I can present even more on, maybe for the next conference, doing webinars, doing podcasts, getting the word out. But absolutely, from on an individual level, if there are people out there, doctors out there, practitioners out there who need more information, they should absolutely contact ILADS and ILADS will direct them to whoever is best, whether it's me or somebody else. Yeah.
Yeah, and I want to respond to, because I've heard it as well, some of these naturopaths and functional doctors claiming that the root cause medicine, is being violated by these GLP-1s and some of these things we're discussing. But I think it's such a narrow-minded response because even look, we're a Lyme disease podcast. I was impacted by Lyme disease, but we've grown because of doctors like yourself, where I've learned it's never just Lyme disease. It's never just Borrelia burgdorferi. So was my root cause Borrelia burgdorferi? It was a lot of things. And I think if I just addressed the Borrelia burgdorferi, I would have still been crippling sick, right? So we have to be open to that. And if, as you noted so well, if we address the Lyme and the patient is still sick, then Lyme wasn't the root because the patient is still sick. And that happens sometimes, but not with everybody, with some patients. So if the mast cell activation is still there and the Lyme is down, but we address the mast cell activation, the patient gets better, then define root cause, right? So if the goal is to get patients better and these GLP-1 drugs are helping patients calm down the mast cell, and it could be the missing link for somebody to gain a quality of life back, to me, that's root cause medicine. And I think it's a flawed argument, right? So I just think that's something that we have to your point, step back, zoom out, and really focus on the patient component of this and the patient care component. And if we look at it that way, we're never going to think this is a violation of root cause medicine. So I'm with you, and I just feel very passionate about that. So I wanted to put my 2 cents into that component
Oh,
of
yeah.
it.
I think you nailed it. Thank you for saying that.
Yeah.
And I also wanted to mention one thing, just going back to what you said before about autoimmunity and whether rheumatologists are thinking about this. I just thought of this case that might be interesting to hear about because she was a patient that I probably started seeing 10 plus years ago with polycystic ovarian syndrome, Lyme disease, co-infections, Bartonella, Babesia, you name it, lots of stuff. But what was really striking about her was that regardless of the treatment of the vector-borne infections, she always had almost every band positive on the Western blot.
Mm.
And initially, when I started treating her, it was, sort of earlier in my career, it's probably 10 plus years, probably 15 years. Um, she she had I guess what I would do is I would treat her and then I would follow that Western blot and I would look are we losing bands? Are we getting anywhere? And, she sees some things get better and some things, not. And we would just keep pushing and pushing, pushing. And we got to a point where really from a symptomatic perspective, she was amazing. She was swimming, running, working out, doing all the stuff, working full time. But her Western blot, every band, except maybe one, was always positive, right? And we would sit together and we would sort of say, what does it mean? Do you still have Lyme, but you're not really symptomatic? And so what do we do with this? And she definitely had mast cell, but it was really very mild and pretty well controlled, but we still couldn't figure out this antibody thing. And then a few years ago, she was having some difficulty losing weight. Her PCOS had gotten a little bit harder to control, her insulin resistance a little harder. And we tried metformin, which was okay. It's not a GLP-1, but it does have some, mast cell stabilizing properties, actually. So metformin is definitely like a nice thing. It's also good for insulin resistance. And so she got a little bit of relief. But still, we were still struggling with some of her PCOS insulin resistance stuff. And so we put her on the GLP-1. This was again for more from a weight loss PCOS perspective. And she was, again, one of my first patients, along with that other patient who had the brain stuff come back, which was amazing. So we put her on it and, she loses a little weight, but she comes in. And one of the things that was very striking about her was that she had some irritability and some, but not a true mood disorder, but there was always something a little bit more like irritable, not anxious, but there was always stuff, but very, very mild. And I just thought it was her, to be honest. Like I just thought that was her personality. And she started the GLP-1, and after a few months, she comes in for an appointment, and I'm thinking to myself, she's really different. Like she's really very like seems happier, seems calmer. And she's like, yeah, I feel really good. I didn't even realize that I wasn't feeling good, even though I was working out and doing all these things. But a year or two goes by, and we're still measuring her labs. And I just remember this day. It was probably almost a year and a half into her taking this drug. We look at her labs, and she actually only has a few bands positive for the first time in like 10 plus years. And I looked at that and I thought, oh wow. So that's what it's doing. It's stabilizing the
Yep.
mast cell, stabilizing the immune system. And now the immune system is like, yeah, the Lyme was gone. But I just, it just didn't know it was gone. So it kept fighting and kept showing up with these antibodies. Then all of a sudden the antibodies started to disappear. And
That's
along with
wild.
the antibodies disappearing, she just kept feeling better and better.
So the Lyme was gone, but the immune system with MCAS kept mounting these antibodies because it was,
Yeah.
as you said earlier, it was haywire, right? It's like, I don't know, I'm just going to throw out Lyme antibodies. The Lyme's gone. But the GLP-1s calmed down the mast cell activation syndrome. It reduced the antibodies being generated. All that inflammation was down, and her mood changed in a
Yeah.
positive manner, right?
Yeah. Yeah.
That is wild. So you said when you mentioned PCOS, and I'm curious if this is something that you
Yeah.
think is a relationship as well, because one of the things that breaks my heart and Rich's heart is all the young women and all the women who come onto this podcast and say, I suffer greatly from, severe menstrual cycles. People have had hysterectomies. They've had all kinds of,
Yeah.
really, really bad female reproductive system problems from Lyme disease. And many times they don't even get much relief after the hysterectomy because they're just so inflamed. And I think it's probably MCAS. Do you
Yeah.
think that these GLP-1s will help with that
Yeah.
portion of this? Because it's almost all women we interview that have these types of issues when they are vulnerable to share it. But I almost feel like never mind the autoimmune component, never mind, the calming down the mast cell activation syndrome, the neuropsych side of that, but also from a reproductive system, standpoint, I think this is another avenue to be looked at, right?
Yeah, no doubt. So what I started recognizing pretty early on when I sort of discovered this condition, mast cell, I didn't discover it, but I discovered that it existed, mast cell activation syndrome. I started realizing that from the beginning of my medical career, I was always really interested in women's health. And so I took care of a lot of patients with PCOS. And I started noticing that these women with PCOS were always inflamed and they always had, not always, but often had maybe allergic symptoms or they had There's multi-system conditions that didn't quite fit in completely with PCOS, but seemed associated. And so then I realized when I figured out MCAS that PCOS equals MCAS. So
Huh.
I don't have any PCOS patients who don't have MCAS, actually.
Interesting.
Isn't that fascinating?
Wow.
Yeah.
That is, yeah. I mean, my mind is being blown by you right now because I just think I think the missing link in so many Lyme patients is going to be this MCAS component. And
Correct.
now with these tools, I mean, you gave us a wide variety of tools. I mean, I think GLP-1s are going to be hugely impactful, but then there's the herbal side of it, there's a dietary side of it. That's why the carnivore diet side of it has such positive benefits because it's doing the same thing, but in a different way. And we kind of intuitively stumbled upon this. I mean, I remember 5 years ago, people telling us, I just eat red meat and I feel wonderful. And I think that might be why, right? Now we're getting the science is getting better and better and better, and it's only going to get better from here. But we kind of stumbled on it, but here we are. So I mean, man, there's so many people I'm going to reach out to after this podcast and tell them, hey, you got to go listen to this interview, and you got to think about some of these mast cell tools that are out there that you've just given us, the ones that are on your website. I mean, this is going to be, I think, a big game changer for our community as time goes on.
Yeah, no, I agree. And this is a real passion of mine. And I am starting to, I have done some talks on this before, and I'm starting to do more on it because I think we just need to continue. Again, my mission, educate. And so so it's very clear that women seem to be more afflicted than men. Men can have MCAS and Lyme, of course. You have Lyme, right? Or
Yeah,
you had
yeah,
infection. So we're not saying that only women get it, but there are some things about women's hormones that make them more susceptible in some level. And so, that's an area that I think needs to definitely be explored more. We know that mast cells have receptors, like I mentioned, the GLP-1 receptors, but they have receptors to estrogen, progesterone, testosterone, and many other hormones, insulin. Um, and so we know that mast cells actually react to fluctuations in hormones. And so for patients who see huge fluctuations in estrogen during their menstrual cycle, that can induce a mast cell response, which then can induce PMS or PMDD or these other conditions that really that lots of women struggle with. It can cause those sort of pain disorders. We know that MCAS is related to endometriosis. And of course, that can cause a lot of pain and bleeding and lots of things that patients suffer with. I think the infection, there's an infection component, obviously, that's triggering the mast cell, but I really believe it's not the infection alone causing the problem. It's the mast cells that are driving the symptoms. The infections are driving the mast cells.
right. And the mast cell can persist even after the infection is down,
Right.
which is another wrinkle that people have to think about. So I just realized I've had you on for quite a while. So generally, I ask people, my final question generally is, what gives you
Yeah.
hope for the future? And we just touched on that, right? So I'm
Yeah.
going to just change up the question on the fly here. And
Okay.
as time progresses, because nothing changes overnight, right? It's going to take time for people's doctors to adapt. Obviously, you treat patients, but you're more upstate New York or northern New York, and not everybody can come see the brilliant Dr. Dempsey. So as people are going through this, how can they better advocate for themselves in the short term without burning out? Because it's very difficult to be a patient advocate with your doctors and not burn out when you're so unwell.
Yeah. Yeah. No, this is something that I think about a lot. Um, yeah. So number one, knowledge is power. So, really, listening to these podcasts, accumulating information, so many patients are smarter than their doctors, really, they have to be, right? Which is really hard. It's not fair, right? That they have to do all this work while they're sick. But there are, not enough providers out there really who can take care of these patients, right? So you educate yourself, you do the best you can, and you really try to find like-minded people to help you. And if you meet a doctor or a provider who doesn't take you seriously, is not willing to think about things that I've talked about, If they're not willing to even listen to anything that I've said, and you've brought that information to them, move on.
Yeah.
Move on. It's not gonna work. And unfortunately, there are people who live in areas of the country where there's not a lot of options, but there are people who are doing telemedicine more and more. Unfortunately for me, we have to see patients in the office before we can do telemedicine, but there are providers out there who are licensed in many, many states and are able to start to see people. And so, one thing I want to say is that we just formed a new society called the International Society for Mast Cell Activation Syndrome, or is MCAS. We just received our 501(c)(3) designation. I'm on the board of that too, and I'm treasurer of that organization. So I've got two boards that I'm really passionate about. And I see them really as probably a very collaborative, thing. Well, over time, I can see us working really closely together. But the point is, we have this new organization. The hope with this organization is we're going to be able to fundraise and fund research, okay? So we can publish and get this information out there so that we have evidence-based medicine for people who need the evidence-based medicine to treat patients. We're going to have an advocacy component so we can help support patients in the communities. So that by supporting them, we're obviously helping them get the care that they need and really forming a network of providers all over the world for people to get help with. So again, lots of hope, really
Yeah.
exciting stuff. I am really, really, thrilled about this. I think this is going to be a life changing for so many.
Dr. Dempsey, this podcast is going to reach so many. And I just want you to know this has been one of our top podcast episodes. Rich and I
Oh,
always tell our guests that when we end the podcast and we have more energy than when we started, we know that's how it's a good podcast. And I'm just like glowing inside right now. And I'm like, man, I
yeah.
can go and just keep going now. And you've forced me
Thank
to think
you.
about a lot. And I know you've given our listeners a ton of hope. You've given us a ton of science. You've given us a ton of specific tools that can help people in the short term. And as time goes on, we're going to have to continue to share your findings with our community as you continue to make more progress. And anything we can do to help promote both of your organizations and advocate and bring our community to partner with your community, let us know, and we're there for you because we're all in this together. So, Dr. Tanya Dempsey, I can't thank you enough for joining our Tick
Oh,
Bootcamp podcast.
thank you, Matt. My pleasure.